going to invite Dr. Oyeko to the to speak. Dr. Oyeko, this is her second time speaking with us, and we're very excited to have her join us back. She was with us 2 weeks ago. So we hold this Echoes one session for healthcare professionals, but we also hold other sessions every Saturday for pregnant women. And Dr. Oyeko was part of the panelists 2 Saturdays ago, talking to very excited pregnant moms about how to care for their newborns in this time. And she's back to talk to us, the health professionals, where across the globe, we're seeing lots of pregnant women come down with COVID-19. We're taking deliveries right now in Nigeria of pregnant women with COVID-19. Lutz just, had, tweeted about taking a delivery some days ago. And so our question is, after this successful delivery, from a mom with COVID-19, what then happens to the baby? How are we preparing for the baby? How are we going to ensure that we have the right plan in place in the facility and counseling for the mother to make sure that we don't lose our gains by having the baby get infected post pregnancy and post delivery. And so I'm going to hand over the reins to Dr. Oyeko, who will be sharing her slides. Or do you want me to share it, Dr. Oyeko?
I can share it. I think I have it up. Hold on one second. Good morning, everyone, or good afternoon for you. Good morning here in New York. So let's see. Are you seeing a picture of me?
Yes, we can. If you could just put it in presentation mode.
Yes, ma'am. Yes, boss lady. Okay. All right. So good morning, everybody. So I'm a general pediatrician here in New York, which is the epicenter here, at least in U.S., of COVID-19. And I practice in the Bronx. So this is one of the more affected boroughs. I previously had a slide about where the Bronx is, but we're seeing a significant amount of cases of COVID-19, and then also subsequently the children that are being born. I lead the Division of Academic General Peds, so that's our primary care practices. And so where we see the babies in the nursery, but then also follow them in the ambulatory setting. And so given the diversity of participants today, so I'm kind of struck this in a middle tone in terms of this, but I guess depending on the Q&A, we can definitely get into more in depth. I wasn't sure who all was going to be on the call, so I didn't want to, I got technical, but not super technical. So we'll definitely be able to go into some in-depth. I know the learning objectives talked about kind of the antepartum care. I'm a pediatrician, so I'm not going to speak to that. I'm going to speak about kind of what happens after the baby's born, and kind of what our experience has been here and providing and setting up structures to care for these infants in the nursery. So thank you so much, Kendra and NECA, for the invitation. I'm not going from the next slide. So I'm going to talk a little bit about preparing the facility for delivery and just some of the considerations. And again, this has to be tailored to your context. Talk a little bit about delivery room practice if you are going to attend deliveries, and then spend a bit of time in terms of caring for the newborns and what we're doing in our ambulatory clinics. And then just some follow-up, I guess, recent things that have been published about the inflammatory conditions that we're seeing in children. So setting the stage, it's important for us to just see in terms of where we are globally. So this is the data from the WHO. And so the deeper blue hues are the cases, higher number of cases. So the United States here, significant amounts of cases. And then here in terms of the preponderance of cases across Africa. And you can see really the burden is really in South Africa, but we definitely see in West Africa that there are a growing number of cases every day. So far as of last night, there are 23,000, a little over 23,000 cases that have been confirmed, and a little under 1,000 deaths. So the burden is starting to increase a bit more in Africa. So this, we're starting to see the peak and starting to trend off a little bit. So the World Organization says that all mothers have the right to high quality care, both in the antenatal space, newborn space, postnatally, and then also mental health. And I'll talk a little bit about that in this context and what we're doing. So these things I think are obvious, and these are known in terms of the moms, but it was interesting to see the poll questions in terms of how many people still don't think, hand washing is valuable. So it's interesting even amongst fellow healthcare workers that the value of healthcare, of washing our hands, is still not seen as, it's not 100% of you that responded. So I think it's just for us, because we're the ones that are delivering the health messages, it's important for us to also know what are the things, the messages that we're supposed to be sharing with our families. So definitely washing their hands, avoiding touching their eyes, nose and mouth, putting space, and then coughing, covering their cough. Just a word in terms of hand hygiene, I think it's important. I'm here in the hospital, I'm inside my office, so I don't have on my mask, but the minute I walk outside the door, I gotta wear one of my trusty dandy masks. And we're doing that, but then in addition, we're also recommending the hand hygiene the entire time. And in the hospital, we're doing, hand sanitizer, or also encouraging people in terms of washing their hands with soap and water. So what are the considerations for facility preparation? So I work in a quaternary care center. We have 2 well baby nurseries. And prior to COVID, we were having the children room in with the mommies, so that the babies were born and then they were in the same room with the mom. Then COVID hit, and so the current recommendations are to have a conversation with mom, if possible, and their support person, if they would like, if we're concerned about mom having COVID, whether or not they want the child to stay in the same room with mom, or if they prefer that the baby go to the nursery. If the baby goes to the nursery, then they are put in an isolation, a separate room of the nursery, so that they're isolated from the rest of the babies in the nursery. The other big issue is staffing, in terms of not just the providers, but also your nursing staff, your techs, and then also your administrative staff. So it became, at the height of the pandemic, I say like 4 weeks ago, we were also having the issue of secondary infections within our healthcare workers. So our cadre from the providers, our cadre of providers started to slowly dwindle. So we had to cross-cover several of our nurseries, and that became challenging. So one of the things is you're planning for potentially a surge of cases is for you to begin to start thinking about your backup schedules, and thinking about who would be able to come in the event that somebody got sick, because that was something that we had to quickly and rapidly deploy. Like I myself actually had COVID, and the weekend that I got sick was when I was supposed to round. So we had already had a backup schedule in place, and so was able to call in somebody. But if we hadn't done that, it would have been difficult. So that's just one insight just from this, in terms of from an administrative perspective. The other is having a conversation in terms of your leadership team about what are the visitor policies during and after delivery. So at our institution, we still allowed the person to have at least one family member, support person with them during delivery. Some institutions in New York had actually, for a brief period, had said, you couldn't have anybody with you. But that's difficult if you're welcoming a new child into the world. So we didn't do that. But it's important for you guys to have clear conversation about what those policies are, and then who's going to enforce that. So we also had to employ our security team to be able to, if someone was getting to be difficult, or they couldn't, they wouldn't leave, that they also would be able to nicely remove the person or say that, hey, that they can't be present. But having those conversations up front and that the entire team knows and that they're on board is important. The other is symptom screening for both the patients and the visitors. So when this first started, we were just doing screening based on symptoms. So if the person was having fever, cough, shortness of breath, and the mom was in labor, then they would test. It quickly evolved in terms of that, and I'll share some data from one of our sister hospitals, that many moms were actually infected with COVID, but were asymptomatic. So they shifted to then universally screening moms when they presented to the L&D floor. The other thing was also just doing symptom screening, so asking if they've been exposed to anybody with COVID, if they have any symptoms at the time, and being very concrete. Because what we realized was that they would check in with one person and not tell them the full story. Then they check in with the nurse, and then they'd be like, oh yeah, I had a fever. Oh yeah, I had a cough. And that has implications because they've now interacted with several members of the healthcare team, and that team member may not have been fully donned in their PPE. They may have just had a mask on. So one of the biggest things in terms of changing this was, one, being able to then appropriately ensure people had on PPE as needed when they were assessing the patient. In terms of visitors, as you come into our institution, you now have to get your temperature checked. So anyone, any employee, but also any visitor. And then any visitors, all of us are wearing masks when we come into the building. So that's one thing that happened. At the beginning of the pandemic, we weren't doing that, but very quickly, in about 3 weeks in, all of our entrances. The other issue that they did was that they locked down several entrances to ensure that we directed the flow. So that may be something for you to think about in terms of what are the ways of ingress and egress into your facilities, and being able to identify, okay, how many entrances do you have? And perhaps during this time, you only have 1 or 2 entrances that people come through. Because that was the other issue for us. We're a big complex, and people were coming in, and if they're coming in and they're coming in sick, that's going to be potentially infecting our workforce, as well as, the patients that are being seen. A word about testing, we're still in the same, it's gotten better. So when I think about when I first got sick in March, where, they were only really testing people who had traveled internationally or had been exposed to someone. For healthcare workers, it was challenging to get testing. Now, it's a much different story. I had a staff member who came in sick on Monday. We were able to get the person tested the same day, got the results later that evening. So the turnaround time for the testing is a lot faster. So the biggest thing is finding out in terms of the capacity of your ability to be able to do testing on site, both for your staff, because that's important for them to know, but then also for your patients. And there is testing available. It's the same swab, but we would do testing for the infants as well. I'd be remiss in terms of talking about preparing your facilities without talking about supply chain. So one of the biggest things that we bumped up against in I think every place is just having, adequate personal protective equipment. So having gowns, gloves, masks, and face shields. So we had, a lot of masks and gloves and the like, but gowns became, a hot commodity at the beginning. So it became a situation that, and even the N95 mask, the nurse at the beginning, the triage nurse was the one that was the steward of the N95 mask. And then she would give it to the person for their shift, and they needed to hold on to that and could use it for 4 days. As we started getting more supply, that eased up. And so now every day you can go get a new mask. But at the beginning, it was, you got your mask and you were carrying it in a paper bag and you had that. So it's important, in whatever workflows you guys are going to have, to be able to identify, how you're going to distribute PPE, how many days that people will have it, and just in terms of that piece there, because we had said to providers and staff that if you did not have your personal protective equipment, you should not go into the room to see a patient. Like, you should not put your personal health at risk if you're not adequately protected. And so that was something up front at the beginning. I said, if you clinically feel like the person, you need to wear it, then you need to have it before you're going into the room. The other is just your other supplies in terms of that, because what we noticed is a lot of things come through China, and things got slowed down in terms of even our regular supplies. So just doing an inventory of what you have and then what deliveries are on deck, because we realized just the basic other things like diapers and formula and, you know, those kind of things that, and not that we're giving out formula all the time, but for the kids who needed it, we didn't have, you know, it was hard to get for some of our patients. The other is, I'd say a word about cleaning and disinfection schedules. We had to, because, let me back up. We had situations where, as I mentioned, that people had secondary infections. So we had staff who got sick, and it was kind of a domino effect. And one of our administrators, she was astute to actually start tracking the number of staff members, providers, nurses, techs, front desk staff, who were getting sick at the various buildings. And so she was able to identify that there was a cluster in the building, because typically for us, you know, we get tested it by our occupational health service. They're not necessarily collating the data by location to say 10 doctors or 10 staff members from one location are getting sick. So they were able to track and realize that we had several clusters at our practice. And so we had to shut down the practice and do a thorough deep cleaning of the building top to bottom before re-entering and reopening, because we know that the virus can stay on surfaces. So it is important for you to think about, beyond your normal cleaning regimen, is also keeping track of who's getting sick, so that if you have clusters, that you may need to do a thorough deep cleaning of your facility and the like, because shutting down is never something we want to do, but also we don't want to put people at additional risk. So we were able to do some things, shift into another building while we shut down one building to clean, but it's important. I'd say related to this is also the social distancing for staff. So even in the offices, that time we ended up moving people, we physically took out tape measures and measured the distance between people's desks and the different workstations, so to ensure that they actually had social distancing. And the same thing when they were on lunch break and the like, so that we were minimizing the spread between even our workforce and our colleagues that are here at the job. So these were some of the considerations that we took in place just practically in our ambulatory clinic, but then also as we started to launch this clinic for infants born with infants born to moms with COVID-19. We're going to go through and then take questions at the end, right, Kendra?
Yes, questions
Okay.
at the end.
So just a word in terms of attending deliveries. I don't know how many of you do go to the actual deliveries, but if you do, typically the recommendation is wearing gown and gloves, and particularly if you can, longer gloves, and then having either an N95 respirator mask or eye protection goggles. And then also, or there's some sites that have these air purifier respirators that also have eye protection. Most of us, quite frankly, just use N95 masks with the eye goggles or the face shield. And this is because if you have to do a resuscitation and there's some aerosolization of particles, this would protect you if you get any of those aerosolized viral particles during the resuscitation. So a word about universal screening. So this was a paper that was published by New England Journal of Medicine from some colleagues at Columbia. It was published last week, and it shared just their experience in terms of doing universal screening for the SARS-CoV-2 virus, which is the virus that causes COVID-19, and on 2 of their maternity units. And they show that the majority of the patients who tested positive were actually asymptomatic. So 84.6% of the individuals who tested positive were asymptomatic. But a smaller proportion, like less than 2%, actually presented to the labor and delivery unit with symptoms. Sorry, I'm looking. This is the 13.5% that's asymptomatic, and then the 2% that were symptomatic. And then they had about 85% that were negative. So this was important to know, as I alluded at the beginning, that some moms were actually testing positive but didn't necessarily present at the time of delivery with symptoms, but then during their postnatal course started to develop fever, cough, and the like. So this screening was helpful to inform how to do isolation, but then also how to care for both the mom and the infant, and then also help to guide the PPE that was used in caring for these dyads. The WHO guidelines currently state that, any asymptomatic, because of this asymptomatic transmission, that they recommend that all women with any kind of history of contact with someone with COVID should be carefully monitored. So even though they, at the time that they may present to you, don't have symptoms, they can develop symptoms during the course of their labor. And so just monitoring for that, because we had many stories of that transition happening. The other is just what you all do already, which is that the care should be women-centered, respectful, and be ready to be able to deal with any kind of maternal or neonatal complications. And then also thinking about the role of mental and psychosocial support. We live in difficult and challenging times right now, and then trying to deliver a baby in the midst of a global pandemic is difficult. And then the normal things that we do, both in the hospital and then when the person goes home, we're not able to do them. So for some families, we're starting to hear that many of them are beginning to feel anxious and isolated during the time that they, during the delivery process and then even postnatally. The other piece is just this WHO has also just recommended that there be information provided to people about infant feeding and how to prevent the virus. So the WHO website has actually a lot of infographics that you can download and print for your different facilities. There's no evidence right now that pregnant women who have COVID, that there's a higher risk of severe illness or fetal compromise. We also know that they should be encouraged to attend their visits, and some people are doing that. Our OB team, and I think we've heard on other calls, have been doing a hybrid between face-to-face visits as well as doing telephonic and video visits. So that may be a possibility to think about how you organize the antenatal care and what visits really need to happen in person and what could be done over the phone to support moms. In terms of infants born to mothers with COVID-19, as of current data, again, it's always still evolving. It's not clear right now if mothers can transmit COVID-19 while the baby is in the womb. We don't know. We know that there are some low rates of transmission during delivery, and we know that there is small cases of babies getting COVID-19 after birth. Again, there haven't been big enough case series. We're actually going to be participating in a registry to begin to just track the experience of the babies that we've had so far. But we know that infants are at higher risk for respiratory viral infections in general. So if there is a postpartum mom who has COVID-19, the current recommendations from like our professional society is to consider recommending separating mom from infant in the immediate postpartum period. If that's not possible, they may consider employing the help of others in the care of other infants. They have to be mindful in terms of who those other caregivers are, because if those other caregivers are elderly or have chronic disease in terms of hypertension, diabetes, and cancer, that might not be the best person to be engaged in the care. If it's still not possible and that's not possible, mom should wear a mask, and if she can't get a surgical mask, some sort of face covering would be recommended, definitely. Ideally, a surgical mask would be the thing. And then practicing hand hygiene, so washing the hands with soap and water or using hand sanitizer if possible. For right now, we know that COVID-19 has not been detected in breast milk, And the WHO, I sent it to Kendra, has created a really nice FAQ for questions related to breastfeeding in the context of COVID. So mothers can pump or express their breast milk to allow others to feed the baby. If she's not physically able to feed the baby, we do recommend, like if mom just coughed and sneezed and some of the respiratory particles got onto our breast, we definitely recommend that mom should be cleaning the breast prior to initiating breastfeeding. But they don't necessarily need to wash their breast every single breastfeed. But if they know they sneezed and coughed, it's important to clean both the breast and the hands and any other surfaces that might be around. If they're using a pump, they need to make sure that they're cleaning the surfaces of the pump as well after each use. Other caregivers should be wearing masks and perform the hand hygiene within 6 feet of the newborn. And it's hard because some families, there are multiple children in the home. So it's hard to actually, do social distancing in the home. But I think it is to just have that conversation about the potential in terms of doing that. And then there is testing available for infants. We typically do testing through nasopharyngeal swab and then a swab of the oral pharynx. I think I talked about this. So the only other thing in addition to the breastfeeding and feeding support is just also having the conversation with the parents and the caregivers about this potential separation and then what that may mean, and then providing emotional support, so psychosocial support for families during this time. Because this is a joyous time. They're bringing a new life into the world. And then now there are all these new rules about how you're supposed to integrate. But we also want to make sure that the baby is fine, the mom is fine, and then any other children or family members remain healthy. So just a word, if the mom is physically unwell to breastfeed, she can either express breast milk, there can also be relactation, or using a wet nurse, or donor human milk if that's possible. This is the decision tree that the WHO has created. So it kind of walks through all the different permutations. If the mom is suspected to have COVID, yes. If she's well enough to breastfeed, if yes, then what I've discussed. So it kind of walks through all these scenarios. So this is helpful just in terms of having these conversations with mom, and this in the resource that I sent forward. If for some reason mom is really, really sick and is not able to, definitely, providing formula is another option. But we know that breast is protected. Breast milk is protective, and so definitely if we can encourage that, that's ideal. So just reminder in terms of I'm a pediatrician and the things that we definitely recommend in terms of the warning signs of illness. So fever, so looking for either low temperature or high temperature. If the feeding patterns are abnormal, if the kid is lethargic, any changes in elimination, any changes in respiration, any changes in appearance or jaundice. We recommend right now, so we, as part of this, because we started to see a lot of moms coming into labor and being symptomatic, so one of the things we wanted to limit their dwell time in the on the L&D unit, we started to discharge people within 36 hours. And so to be able to do that, that requires having a receptor site, a primary care provider who's going to be willing to take care of this kid and follow this child immediately after discharge. So we typically recommend seeing the babies 1 to 2 days after birth, or either if we can't see them in person, but doing a phone follow-up to assess the feeding, the weight gain, the diapers, and the like, and then doing frequent follow-up. Our infectious disease specialists recommend that we see the babies in our special clinic for at least 21 days from birth. So we would, we actually set up one practice. We have 19 primary care practices across the Bronx, and we dedicated one of these practices that would see all the newborns that are born to COVID-positive moms. And the thought was to, one, conserve PPE, but then the other was it was close to the nursery, and the team already was familiar with the protocols in terms of assessing the baby. So we do in-person visits, and then for several of the visits, we'll do telephone or video visits with the family. If the mom is too sick to come out, we can do video visits with mom before to get her questions and concerns. And then if the child comes with a parent or another family member, we can then, video chat the mom in. But again, we're looking for these signs of illness because there's not any specific stigmata. It's the normal things of neonatal sepsis that you're looking for, which is really fever, lethargy, cough, trouble breathing, and feeding problems. This I won't talk about. I think the other big practical thing to have conversations about is who's open and which doctors are currently open and available to see patients, and particularly for emergency situations. So we, at the beginning of the pandemic, we decided that we would remain open for newborn follow-ups and infants, but our emergency room kind of significantly reduced the volume of patients that they were seeing. So then we opened up like an urgent care for people who were sick, but we didn't want them to come into the primary care practice because we were trying to keep the primary care practice clean for the new babies that were coming in. So it's important for you to look at your health system and think about what doctors are currently available, who's delivering care, and where can families get emergency care if they need it. The same thing with the hospitals in terms of what, the public health messages are like stay home, but we don't want people to stay home if they're actually sick or they need care. So that was the big thing, is knowing very quickly where to refer families to if the child or the mom was having any complications and needed to be seen. The other is practically, we realized that in terms of, do they have a thermometer at home? So most people are just, touching the forehead and or the arm and saying, oh, the child feels warm. But it was important for us to make sure our moms also had thermometers or access to somebody with a thermometer. The other thing was, because we were trying to limit how much people were coming into the office, we were trying to have parents weigh the baby at home and using just a regular scale. But what we realized quickly is that in some instances, we would weigh the mom on a regular scale, then put the mom and the baby together. Mom would be holding the baby on the scale, and then subtract the difference. In some cases, we were noticing that the baby wasn't gaining weight. And so we've recently just gotten a bunch of infant scales to give to the moms so that they can have it at home, and then this way they're not having to come in. I recognize that that probably is not going to be something practical for everyone, but it's just important to see how the baby is gaining weight. So however you're able to do that estimation, because we still want to make sure that they're growing. This is one of our practice sites, and so this is me with our nurses, and then these are the face shields that we're using for these visits. This is one of our physicians who's getting donned and before she goes into the room. And so we have a nurse here that's helping the physician get dressed, and then we have another nurse that's serving as a monitor to kind of watch to make sure that there's not any cross-contamination when they're putting on the PPE. So there, she's wearing a gown, an N95 mask, and then she's going to put on one of these shields. And then the doctor goes into the room, and they actually do the weighing of the baby, the whole exam, and then comes back out of the room and then docks. But this has worked out pretty well in terms of having this workflow in terms of the nurses here. We've seen, we see on average about 5 to 7 babies a week at the practice so far. We started this April 1st. So in terms of the babies that are coming to this practice now. Just want to pivot a little bit to talk about COVID in children. So I work at a children's hospital, and interestingly, April 5th or 6th, we actually shifted where we gave up beds in our children's hospital to take care of adults with COVID-19. Because overall, the number of children who were affected is significantly less. And those that were affected were fairly mild. The ones that had a more complex course were those who had chronic heart disease or respiratory disease or neurological deficits. Those were the kids that were more affected, and those were the kids that needed to be vented. Most kids ended up having just fever, cough, shortness of breath as their main symptoms, and most kids did not have any symptoms at all. I just want, as many of you know, there is, recently there's this the people that we've been seeing even in our children's hospital and our main hospital that have been getting significantly ill is because there's this complex interplay between their normal immune response and then that's triggered after seeing a viral infection, and then the increased inflammatory response that targets these healthy tissues. And recently, the UK Pediatric Society noted that they were seeing a small rise in these critically ill children, some who had tested positive for COVID, but were presenting with overlapping symptoms of toxic shock and atypical Kawasaki's disease. So just wanted to briefly discuss in terms of what Kawasaki symptoms look like, what toxic shock, and what this new inflammatory condition we're seeing. We haven't seen cases like this. There's only been like 3 in New York so far. But I think as there's an awareness of it, more people are looking to see if they notice this pattern. So Kawasaki on the left hand is typically a febrile illness that happens in children less than 5, as many of you know. And the hallmarks are fever, swelling of the hands and feet, rash, irritation, conjunctival injection, swollen lymph nodes, and then irritation of the mouth, lips, and throat. Toxic shock syndrome, we know typically will happen after Staph aureus or streptococcus infection. And the symptoms are somewhat similar in terms of fever, diarrhea. They tend to have more of a red skin that looks like a sunburn, vomiting, conjunctivitis. They'll have hypotension, confusion, and then muscle cramps, muscle aches. This new kind of COVID-related inflammatory condition, what they're noticing is that some people have these symptoms with or without fever. But they're also noticing people presenting with diarrhea, abdominal pain, vomiting, and then ultimately progressing into septic shock with increased heart rate and hypotension. So it's just, I'm bringing this as an awareness to you just in terms of you may see cases where people are presenting atypically, and this may be actually an example of what we call cytokine storm, where you're seeing this, revved up immune response that's not just attacking the lungs, but other parts of the body as well. Other considerations that we have had to deal with in this is food insecurity. So in the fact that this is, pandemic here, New York State is on pause, many people have gotten laid off or let go from their jobs. So we are noticing people having difficulty getting food. So we have food pantries and the like, but we're seeing the lines for that growing longer and longer. And one of the issues that we are noticing was also this was happening to our moms who were coming in for these newborn follow-up visits. So for some moms who were too sick to feed, they wanted to, do formula. They were saying they didn't even have formula to give, and they didn't have food to eat. So this became another pandemic or crisis in the midst of this. So this is, this might be just unique to our context here, but we now, as part of our assessments, we do social determinants of health screening and really trying to ask if people have difficulty getting food, connecting them to resources to be able to get food from a food pantry. We actually, went out and we got a grant to be able to buy some supplies for families to be able to give it out in the practice because it was happening so frequently over the last couple of weeks. The other is access to water in terms of, because some people's housing has been unstable and we have a high homeless population, that is the other thing. You can't wash your hands if you don't have a place to live and you don't have access to water. So just having conversations about where people are going back to after delivery is important in terms of their housing context. The other thing I'd say a word is about the impact on interpersonal relationships. People are home and they're, been home for extended periods of time. And as part of my division, we also have a child abuse program. And we've noticed that, unfortunately, child abuse is still happening. And so people are getting frustrated, being home and trying to homeschool their kids and take care of the kids and deal with the stress of this. And so unfortunately, that's leading to, violence on their children. but then also interpersonal violence between couples. So just being mindful of that as well, in terms of assessments there, because it's not something that people thought about. The other is, as I mentioned, people are afraid and people are really scared. So the other thing is just the isolation that people are feeling. As I said, this is normally a joyous time, families coming to visit and seeing the baby, and now that can't happen. So also just asking the moms and the family members what their support networks look like. And then just the impact of this collective stress on the person's health, both the mom and the baby, and the extended family. So I want to just close or wrap up my remarks so that we can really have time for Q&A. You know, over these last 6 weeks, I've definitely looked like this. My hair has been pulling out just because every single day there's been some new issue, some new program we needed to start, somebody's sick, we don't have this, we don't have that. And it's been every single day that's been that. I've also had this where I'm, stuck, on my laptop, trying to, make all the different workflows and set up things. It is very challenging during this time because a lot of this stuff, we're making it up as we're doing it. There's not been any context or lessons, learned that we can pull from it. People are starting to write this stuff up, but a lot of it, you go to PubMed and you can't find anything. Definitely juggling multiple things. So not only taking care of my division and my staff, but then my own patients that I take care of, my family, the education of our trainees in terms of the residents and the like, trying to still be academically productive. It's a lot, and it's kind of crazy making behavior. And, there have been many days that I've looked like this where I've just been in a corner, just like it's a lot and stuff. But I think the thing is, this is a marathon. This is not a sprint. And ultimately, the goal is to get to a place where you're, being able to be back to your authentic self, and really being able to be at peace with who you are and just recognize you need to take those moments. So I wanted to take the last couple of moments just to share just some thoughts, just from tips from being on the front line here and just things to think about. It's important to pace yourself. When your surge happens, the volume is crazy. And we would make plans at 9 o'clock in the morning, and by 5, 6 o'clock, the whole thing would have to be scrapped and start all over again. We opened up a new clinic in 72 hours because the babies were coming faster than people were planning for it. So just pace yourself, but know that, this is a long road. Like we were thinking, there's going to be 4 weeks. It's almost 2 months. Flex your no muscle. So it's something that I don't do well, but I think it's important to start to do because you're going to get burnt out if you don't. Listen to your body. If you need rest, take the rest. I ended up, I think on some level getting sick was actually, God speaking to me to say, like, look, you need to have several seats. And you need to take a moment and take your own advice and rest. Because, unfortunately, we lost like a colleague and was a revered surgeon from this virus. And I think it drove home like, this is real, like we could get sick and we could potentially lose our lives. So you need to make sure that you're listening to your body. If you're feeling sick, that you take stock and you actually don't explain away the symptoms, because that's what I was doing. I, was feeling short of breath and feeling scratchy throat and was just thinking I was just tired. And it turned out, no, you have COVID. The other is helping parents and families to brainstorm their own solutions. So you don't have to be the panacea for everything, but you can ask them like, hey, how would you do X in this context? Take the time to unplug and take the time to recharge. And then feel the feelings. It's okay to be upset. It's okay to be frustrated, annoyed. Feel those feelings in a respectful way, but feel those feelings, because if you bottle it up, it's going to come out at some point. It's important for you to do something to recharge yourself also. So if it's resting, exercising, eating healthy, praying, dancing, reading, whatever, but you need to do something. And then you need to have a conversation with your family in terms of who's going to help you with your other parts of your life. I'm fortunate that my husband is very, very supportive and really stepped up, but it's important to have an explicit conversation about what you're going through and what you're seeing on the front line. Because for many people, we just had a esteemed ER doctor commit suicide, you know, because she was working on the front line and was just overwhelmed and just got to a place that she couldn't take it anymore. So it's important. I know that this is not the intent of this webinar, but I'd be remiss in not saying it, because as we're getting close to thinking about reopening and re-expanding, thinking about the provider and the staff's mental health is really top of mind, because you can't go back to normal if you have folks that are walking around like zombies. And it's just important to have that conversation. I think that's it. I know I went through a lot in a very short period of time, but my hope is that we have time for questions. And thank you.